This is gonna be one of my favorite series to teach you guys. See, the great topic is jaundice. Under this topic, there are many subtopics that you need to know. But the problem is that these subtopics are present in different subjects. And the problem with university lectures is that these topics are taught in different subjects at different lectures at different times. So, integrating the concept from these topics becomes really difficult. What I'm gonna do is take all these important topics and then teach you them in a series so that the whole picture of jaundice becomes crystal clear. For example, you know this much that jaundice has something to do with bilirubin. So first you need to know what is bilirubin and where exactly in our body is bilirubin produced. Now that's a topic of biochemistry. Then you need to learn about hyperbilirubinemia, congenital and acquired, along with pre-hepatic, hepatic and post-hepatic jaundice. Now that's a topic of pathology. Then what jaundice does to your body, the discoloration of the skin, sclera, mucosa and interstitial fluid. That's a topic of physiology. Then as I teach all of these in a story fashion, I'll be using lots and lots of diagrams which are a part of human anatomy. And that's how I'll be integrating everything together. So all you have to do is relax, take a deep breath and listen to my lecture like a story. Visualize whatever I'm drawing like a movie. So that's all you have to do. Starting off with bilirubin. Your red blood cells, they have an average lifespan of 120 days. After 120 days, the young red blood cells have become old and they get destroyed. See, the young red blood cells, they are flexible. But the old red blood cell, they have lost that flexibility. They are no longer flexible. Just like humans, we youngsters are quite flexible. But as we grow older, let's say we reach the age of 50 years, our joints, they become rough, our muscles stiff, blood vessels hard, back rod-like stiff. So the whole body loses flexibility as we grow older. Similarly, red blood cell as well, when it is young, it is flexible, but after 120 days as it has become old, it loses that flexibility. It loses its flexibility. Okay. So 120 days have passed. The red blood cell has become old. It has lost its flexibility. Now it needs to get destroyed. Where does the red blood cells get destroyed? There's an organ in the body which is called the graveyard of RBC, because majority of the old RBCs get destroyed there. You know what that organ is? That's none other than your spleen. So this old red blood cell, it enters the spleen. It's not just that only old red blood cell enters the spleen. The old red blood cell, the young red blood cell, blood as a whole, they enter your spleen. Now inside spleen, you have the spleen capillary, which contains gaps. These gaps are referred to as sinusoids. Now hear me out. If this is a young RBC, it is very flexible. See, this is a young RBC. It is very flexible. So it can easily squeeze through this gap, come out, and then continue into the circulation. But this RBC right here is old. It has lost its flexibility. So it is unable to squeeze through the sinusoid. So it is stuck. It is stuck or trapped into the sinusoid. Now this stuck or trapped old RBC that no longer has the properties of young RBC gets phagocytosed by the macrophage of your spleen. This macrophage is a part of reticuloendothelial system macrophage. Reticuloendothelial system includes the macrophages of three organs: the macrophage of spleen, the macrophage of bone marrow, and the macrophage of liver. So the old RBCs can get destroyed by the macrophage of spleen, the macrophage of bone marrow, and the macrophage of liver. But since majority of the old RBCs get destroyed by the macrophage of spleen, that's why spleen is regarded as the graveyard of RBC. Okay, I hope till now you have understand. You had your young RBC. After 120 days, it becomes old and loses its flexibility. So inside the spleen, there are capillaries with sinusoids. The young RBCs can pass and squeeze out of these sinusoid and continue into circulation. But then the old RBC, it is quite stiff, so it is unable to squeeze through the sinusoid. It gets trapped in the sinusoid, and then these trapped old RBC that no longer contain the properties of young RBC gets eaten up by the macrophage of your spleen, which is a part of reticuloendothelial system. Okay, so this in blue, I have zoomed into the macrophage, and inside this macrophage is none other than our RBC. Now let's break this RBC into its various components. What is RBC? It is a bag filled with hemoglobin. The bag being none other than the plasma membrane. What is plasma membrane made up of? It is made up of lipid and protein. So when lipid gets broken down, we get free fatty acid, and when protein gets broken down, we get amino acid. Plasma membrane, done. Now what is inside RBC? Cytoplasm. Cytoplasm contains number one, enzymes. Tell me one enzyme. G6PD, glucose 6-phosphate dehydrogenase. Have you heard of G6PD deficient patient or G6PD deficient anemia under hemolytic anemia? I've already taught you this under the topic of anemia, for which I have made a single video explaining all the concept and all the types of anemia. Was that out after this lecture? Okay, so there's enzyme. The enzyme gets broken down into amino acid as well. Finally, what remains? What remains is hemoglobin. Let's break down hemoglobin. You know the structure of hemoglobin, right? It contains 4 heme and 4 globin. 4 globin. Out of 4 globin molecules, there's 2 alpha globin and 2 beta globin. Be it alpha or beta, they are at the end of the day what? Protein. And protein is broken down into amino acid, and then the amino acid gets reused. Now we are just left with heme. Do you know the structure of heme? Heme is made up of 4 pyrrole molecules. What? 4 pyrrole molecules. 4 pyrrole molecules. 4 pyrrole molecules connected with one another with the help of methane bridge. Methane bridge. And in center, there is iron. Again. So what do we have? We have 1, 2, 3, 4 pyrrole molecules connected to one another with the help of methane bridge, forming a single ring, which is called the porphyrin ring, and a central iron. So let's degrade this as well. Let's break it down. So first, the iron from the center is snatched out. Okay, so we are taking out that iron. Iron snatched out. And this iron is then what? It is stored. It is stored in the form of what? It is stored in the form of ferritin. The ferritin polymerizes. The ferritin polymerizes to form a larger molecule, which is called hemosiderin. So the iron snatched from the heme of hemoglobin is stored in the form of ferritin, and ferritin polymerizes to form a much larger stored form of iron called hemosiderin. So both ferritin and hemosiderin are stored form of iron. Okay. Now what remains? What remains is the ring of the heme of hemoglobin. The ring of the heme of hemoglobin gets degraded, and what we get is biliverdin. And then this biliverdin gets reduced, and what we get is bilirubin. Now there are 2 enzymes required here. Number one, for the degradation of the porphyrin ring into biliverdin, and number two, for the reduction of biliverdin to bilirubin. So the first enzyme which degrades the ring of the heme is heme oxygenase, and the second enzyme which reduces biliverdin is biliverdin enzyme for reduction reductase. And finally we get bilirubin. The term bilirubin is there. So what is bilirubin? Bilirubin at the end of the day is the end product obtained from degradation of hemoglobin. So the hemoglobin present in the RBC gets degraded and broken down, finally giving us a waste product. So the end waste product obtained from the metabolism or degradation of hemoglobin is bilirubin. Okay, another concept. The bilirubin that we get from the degradation of hemoglobin is unconjugated bilirubin. Few properties of unconjugated bilirubin. Number one, it is unconjugated. Number two, it is lipid soluble. Number three, it is non-polar. And number four, it is toxic. Remember the 4 points. It is unconjugated, it is lipid soluble, it is non-polar, it is toxic. See, actually the property is just two. One, that it is lipid soluble, and another that it is toxic. It is lipid soluble because it is unconjugated, and lipid soluble are non-polar. See, these two properties are responsible for two things. Number one, since bilirubin, unconjugated bilirubin, is lipid soluble, it can easily enter inside tissue because lipid soluble substances can easily penetrate through the plasma membrane. So the unconjugated lipid soluble bilirubin can easily enter inside tissue. Second, since it is toxic, once it enters inside the tissue, it will destroy the tissue. So you don't want two things from happening, okay? You don't want two things from happening. See, bilirubin produced in the macrophage of the spleen from the degradation of hemoglobin is unconjugated. Since it is unconjugated, it is lipid soluble, that is, it loves lipid. And lipid soluble substances, they can easily cross through the plasma membrane of the cell. So since bilirubin is lipid soluble, it will cross through the plasma membrane of the tissue. But this bilirubin is what? It is a waste end product. Waste. It is toxic, so it will destroy the tissue as well. So we don't want two things. Number one, we don't want this bilirubin to enter inside the tissue. And number two, since it is toxic, what does our body do to toxic substances? It excretes it out. So our body needs to excrete out the toxic unconjugated bilirubin. How does it do so? See, this is how. So finally, from the degradation of hemoglobin, we get unconjugated bilirubin. This unconjugated bilirubin from the macrophage is thrown into body circulation. It is thrown into body circulation. Now this unconjugated bilirubin is in body circulation. Let's draw it. Unconjugated bilirubin. There is tissue in the periphery. Tissue in the periphery. What did I say? Unconjugated bilirubin is lipid soluble, so it can easily cross through plasma membrane. Unconjugated bilirubin, it is lipid soluble. It can cross through the plasma membrane and enter the tissue. It is also toxic, so it will destroy the tissue. But why does this not take place normally in our body? In our body, continuously, old RBCs are getting destroyed, hemoglobin is being degraded, and bilirubin, unconjugated bilirubin, is being produced, which is being poured into body circulation. Unconjugated bilirubin is being poured into body circulation continuously. But then why is it that this unconjugated bilirubin not enter into our body tissue and destroy it? What is preventing that from happening? That is none other than the fact that this unconjugated bilirubin inside body circulation circulation binds with a plasma protein. It binds with a plasma protein, albumin. So what? So this. See, unconjugated bilirubin, it is lipid soluble, plus it is small in size as well. So it is easy, it can easily enter inside tissue. But see now, this unconjugated bilirubin, which is bound with plasma albumin, is now too large in size. And this large molecule can't penetrate through the tissue membrane. It can't pass through the tissue membrane. So it is now present within the circulation. It will not enter into any tissue of the body. First problem done, right? So first thing we didn't want was for bilirubin to enter inside tissue. So that's done. Second thing we want was for body to get rid of this toxic material. And there are two ways our body gets rid of any toxic material. I mean, there are many ways, but two major ways our body gets rid of toxic material. Number one, via feces or stool, and number two, via urine. So how does that happen? Let's see. Okay. Under general pharmacology, you might have already learned that the drugs that we take are mostly lipid soluble. These lipid soluble drugs, once it has been metabolized, once it has been used, it can't get excreted out. First, it needs to go through the liver, where it gets metabolized, so that the lipid soluble drug is converted to water soluble drug. And then this water soluble drug can then get excreted. This lipid soluble drug is the non-polar drug, and the water soluble drug is charged or polar. So the main concept is that first, the unconjugated bilirubin, which is lipid soluble, which is non-polar, needs to be converted to water soluble, which is polar, and only then after that can it get excreted. So it has to go through the process of conjugation. Here is the liver. Here is unconjugated bilirubin. First, the unconjugated bilirubin enters the liver. The first step, uptake. Then unconjugated bilirubin is converted to conjugated bilirubin. As a result, lipid soluble bilirubin becomes water soluble bilirubin, or non-polar bilirubin becomes polar bilirubin, or toxic bilirubin becomes non-toxic bilirubin. The process is called conjugation, and finally it is excreted. It is secreted into body, and then it can get excreted through feces and urine. Okay, so let's see these three steps. What's the diagram here? This whole thing that you see right here is representing a liver, but more specifically a liver cell. So this is your hepatocyte. This is the systemic circulation. This right here is the enterohepatic circulation, the portal system in between liver and the gastrointestinal tract. You know that from your anatomy, right? Between gastrointestinal tract and liver, the blood does not directly go to your heart. First, from the GIT, the blood goes to liver and then to your heart. So in between, that extra circulation is there none. That is portal circulation, or hepatic portal circulation, or the enterohepatic circulation. Entero referring to GIT and hepatic referring to liver. Okay. The liver makes bile. The bile, it goes through the bile canaliculi present within the liver, and then through the right and the left hepatic duct, then the common hepatic duct, which fuses with the cystic duct, forming the common bile duct, which fuses with the pancreatic duct, forming the hepatopancreatic duct, which opens into ampulla vata, which is guarded by the sphincter of Oddi, which opens into duodenum. Which part of the duodenum? The second part of duodenum. You must know your basic anatomy. Duodenum has four parts. The first part, the second part, the third part, and the fourth part. It's in the second part of the duodenum where the biliary system opens. Okay. With that basic anatomy done, let's see what happens to unconjugated bilirubin. So the unconjugated bilirubin gets carried by the albumin to your hepatocyte. This unconjugated bilirubin is then taken up by the hepatocyte. The process, the very first step, as I said earlier, is referred to as uptake. It takes place by facilitated diffusion. Now that unconjugated bilirubin is present within the hepatocyte, it goes through what? It goes through conjugation, and the unconjugated bilirubin becomes conjugated bilirubin. Second step, conjugation. Conjugation takes place. For conjugation to take place, something has to come and conjugate with bilirubin, unconjugated bilirubin. What is that something? There's an acid. The acid is called 2-UDP glucuronic acid. Glucuronic acid. So that gets conjugated. Obviously, an enzyme is required for the metabolism to take place, and the enzyme is none other than 2-UDP glucuronyl transferase, because the transfer of glucuronic acid is taking place. It's the glucuronic acid that is getting conjugated with the bilirubin. So glucuronyl transferase enzyme is required. With that, conjugation is also done. So finally, you have conjugated bilirubin. This conjugated bilirubin, it has two fate. Fate number one, it enters into the enterohepatic circulation. Conjugated bilirubin enters into the enterohepatic circulation with the help of multi-drug resistant protein 3. Okay, but then this conjugated bilirubin, which entered enterohepatic circulation, is taken back into the hepatocyte. It is taken back, reuptake takes place, and that is done by OAT1B1 and OAT1B3. So two pumps, multi-drug resistant protein 3 and OAT1B1 and 1B3. Remember the name of the pumps because you will require them under the topic of congenital hyperbilirubinemia. Okay, so that was the first fate. The second fate is secretion. The third step, it gets secreted into biliary system. And that takes place with the help of another pump, that is multi-drug resistant protein 2. This step is referred to as number 3, secretion. So secretion takes place. Finally, the conjugated bilirubin is inside the biliary system. From the biliary system, where does it go? So hepatic duct, then the cystic duct, again the hepatic duct, the cystic duct, and then inside the gallbladder. Inside the gallbladder, you have conjugated bilirubin. What does gallbladder include? It includes bile. What is bile made up of? It is made up of 3 major stuff. Number 1, bile salt and bile acid. Number 2, the substance that makes up the bile salt and bile acid, that is cholesterol. And number 3, whatever is here, conjugated bilirubin. So 3 stuff, bile salt and bile acid. Number 2, the stuff that makes bile salt and bile acid, that is cholesterol. And number 3, this right here, conjugated bilirubin. The conjugated bilirubin then repasses through the cystic duct, then the common bile duct, then the hepatopancreatic duct, then the ampulla of Vater, passes through the sphincter of Oddi, and then gets secreted into the second part of the duodenum. So finally, the conjugated bilirubin is present in the second part of the duodenum. The conjugated bilirubin inside the gastrointestinal tract, it is acted upon by what? It is acted upon by bacteria, the bacteria of the gastrointestinal tract, and gets converted to urobilinogen. The urobilinogen that is formed by the metabolism of conjugated bilirubin by the action of gut bacteria has 3 possible fates, and they are: number 1, see, the gastrointestinal tract has a connection with your liver via portal circulation. The blood from the heart goes to your gastrointestinal tract, and from the gastrointestinal tract, it does not return directly back to your heart. It goes through extra piece of circulation that is present in between, and that is the portal circulation or the enterohepatic circulation. Entero referring to the intestine, the GIT, hepatic referring to liver. So nutrition, bunch of things from the GIT gets absorbed into the portal vein, the portal circulation. Similarly, the urobilinogen produced also gets absorbed into the portal circulation or the enterohepatic circulation. Urobilinogen. From enterohepatic circulation, it reaches from the entero to hepatic, that is from GIT to liver. And once it reaches the liver, what does it do? It traces back its pathway. That is, it enters the biliary duct, the biliary canal, and return back to the duodenum where it initially was. But not all urobilinogen return back, cause there is one more connection with liver. That is, all the deoxygenated blood from the liver, it comes to the heart via portal vein. So some urobilinogen, it returns through the biliary duct, but a lot of it goes back through the hepatic vein to your heart, and then from heart the systemic circulation, and from the systemic circulation to your kidney. And it is in the kidney, let me show the connection directly from here. So in the kidney, urobilinogen is oxidized to urobilin, and urobilin provides urine its characteristic yellow color. Okay. What about the urobilinogen present within the GIT? It comes out as well. Yes, it comes out along with stool. So in stool, urobilinogen, it gets oxidized to stercobilin, and stercobilin provides stool its characteristic brown color. So that's it. That's the end of the story. Let me revise the whole thing for you with the help of a flow chart. So what do you have? You have initially the hemoglobin. The hemoglobin is made up of heme and globin. Globin is broken down into amino acid, which gets reused. All of this is happening in the macrophage of reticuloendothelial system, especially your spleen. The heme contains a central iron and a porphyrin ring. The central iron is stored. It is stored in the form of ferritin. Ferritin polymerizes to form hemosiderin. What remains is the porphyrin ring. The porphyrin ring gets degraded into biliverdin. The degradation of the porphyrin ring into biliverdin, or the heme into biliverdin, takes place with the help of enzyme hemoxygenase. Biliverdin is then reduced. It is then reduced to bilirubin. Biliverdin is reduced to bilirubin. This takes place with the help of enzyme biliverdin. Enzyme required for reduction, reductase. Now, this bilirubin that is obtained from the degradation of RBC, the degradation of hemoglobin in the macrophage of reticuloendothelial system, is unconjugated bilirubin. This unconjugated bilirubin comes into systemic circulation, where it is carried by albumin. So here is unconjugated bilirubin, which is carried by albumin, plasma protein binding albumin, which takes it to liver, where the very first step of conjugation takes place, which is called uptake. So first step of conjugation, uptake, takes place. So it enters the liver. Inside the liver, the unconjugated bilirubin gets conjugated, converted into conjugated bilirubin. So this is the second step, which is conjugation. Conjugation takes place, I get it, but conjugation with what takes place? Conjugation with 2-UDP glucuronic acid takes place. Since conjugation with glucuronic acid takes place, so the enzyme required for this metabolism, conjugation, is 2-UDP glucuronyl transferase, obviously. Now this conjugated bilirubin has two fate. One, it can enter into the enterohepatic circulation. What? The enterohepatic circulation. Via what? Via multi-drug resistant protein 3. But then it returns back as well. It returns back with the help of what? OAT 1B1, OAT 1B3. See here. So inside the liver, conjugation of the unconjugated bilirubin into conjugated bilirubin takes place. Then this conjugated bilirubin can enter back into the enterohepatic circulation with the help of multi-drug resistant protein 3, which is but taken back with the help of OAT1B1, OAT1B3. But then the major fate of conjugated bilirubin is that it enters the biliary circulation with the help of multi-drug resistant protein 2. It enters the biliary circulation, and this is the third step, that is secretion into biliary circulation. From the biliary circulation, the conjugated bilirubin enters the duodenum, where the conjugated bilirubin gets converted to what? Urobilinogen. Now urobilinogen has 3 fate. Number 1, go back into enterohepatic circulation. See, urobilinogen in the duodenum can go back into enterohepatic circulation, but then it returns back, stresses back the same thing, and then returns back. So it returns back. But not all of it returns back. Does all of it return back? No, some of it enters the systemic circulation and reaches the kidney. In the kidney, urobilinogen gets converted to urobilin, which provides urine its characteristic yellow color. And the urobilinogen present within the gut comes out along with the stool. In the stool, it gets oxidized to stercobilin, and this stercobilin provides stool its characteristic brown color. That's it. Hyperbilirubinemia, really bacha topic, literally, considering most of the defects are congenital. See, hyper means excess, bilirubin is bilirubin, and emia is blood. So the presence of excess bilirubin in blood is hyperbilirubinemia, which begs the question, what is the normal level of bilirubin in blood then? The normal serum total bilirubin is 0.3 to 1.2 milligram per deciliter as written in Robbins. And this total bilirubin contains 2 different types of bilirubin. Unconjugated bilirubin, which is also referred to as indirect bilirubin, and conjugated bilirubin, which is also referred to as direct bilirubin. And by now you must have already known that unconjugated bilirubin is lipid soluble, non-polar and toxic, while conjugated bilirubin is water soluble, polar and non-toxic. See, an increase in the level of bilirubin in blood is called hyperbilirubinemia. If this increase in bilirubin is that of unconjugated bilirubin, then it is unconjugated hyperbilirubinemia. If the increase in bilirubin is that of conjugated bilirubin, then that is conjugated hyperbilirubinemia. Simple. All right. Okay. Now the question is, what leads to increase in bilirubin in the body? And for that, you need to know the story of the metabolism of bilirubin. And fortunately, we have already learned that. We know the story of the metabolism of bilirubin. Now, in this story, there are specific areas or specific pinpoints where pathological defects occur that lead to hyperbilirubinemia. So a short revision of the story of metabolism of bilirubin, but this time it will be stepwise, so that at these individual steps, then you can learn the defects, the pathological defects that occur leading to increase in the level of bilirubin in blood. Okay, so the story goes like this. The young RBC after 120 days becomes too old, and it inside the spleen of the body gets degraded or broken down into bilirubin, or specifically unconjugated bilirubin. So there is production. What? Production of unconjugated bilirubin. the unconjugated bilirubin then enters the systemic circulation. In the systemic circulation, it immediately binds with a plasma protein called albumin. So there is plasma protein binding, step 2. The plasma protein albumin carries the unconjugated bilirubin to the liver for the process of conjugation, where first the liver cell takes in the unconjugated bilirubin, which is referred to as uptake. After uptake, inside the liver cell, inside the hepatocyte, the process of conversion of unconjugated bilirubin into conjugated bilirubin takes place, which is referred to as conjugation. After conjugation, the conjugated bilirubin present within the liver can leak into the portal circulation via multi-drug resistant protein 3. But the leaked conjugated bilirubin is reuptaken, taken back. See, there was uptake here, then it leaked into the circulation, then it was reuptaken into the liver with the help of O1B1, 1B3 protein. So there is reuptake. Now, the conjugated bilirubin present within the liver, it is secreted into the biliary canaliculi. This is secretion. Secretion. The secretion takes place with the help of protein, multi-drug resistant protein 2. After secretion, it flows through the biliary system along with the bile to enter the second part of the duodenum. This is bile flow. So bile flow takes place. What is present in bile? In bile, you have the bile salt and acid. What makes bile salt and acid? That is also present, which is the cholesterol. And this conjugated bilirubin is present. After it flows through the biliary system, it enters the second part of the duodenum. Then within the gastrointestinal tract, the conjugated bilirubin is acted upon by the gut bacteria, which metabolizes it into urobilinogen. The urobilinogen is excreted out of the body, number 1, through feces in the form of stercobilin, which provides feces its characteristic brown color, and number 2, through urine in the form of urobilin, which provides urine its characteristic yellow color. So first, there was production of bilirubin, unconjugated bilirubin in the spleen. Then second, the unconjugated bilirubin bound with albumin, plasma protein binding. Then third, the unconjugated bilirubin was taken into the hepatocyte, uptake. Then fourth, the unconjugated bilirubin was converted to conjugated bilirubin by the process of conjugation. Then fifth, conjugated bilirubin leaked into the portal circulation. However, with the help of OAT1B1 and 1B3 protein, it was reuptaken. Then sixth, the conjugated bilirubin present within the liver is secreted into the bile canaliculi with the help of multi-drug resistant protein 2. Then seventh, it flows along with the bile through the biliary system to the second part of the duodenum. And then finally, inside the duodenum, the conjugated bilirubin is metabolized by gut bacteria into urobilinogen, and the urobilinogen gets excreted out along with feces and urine. Good. You might be disappointed with the fact that I've been revising this topic so many times, the metabolism of bilirubin. But see, I'm gonna make hyperbilirubinemia so easy. Just see what chamatkar I'm gonna do. Boom, 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 and hyperbilirubinemia done. Yep, it's done. That's it. If you know the metabolism, you can pinpoint the defects, and then if you know where the defects are, you know what the topic is. That's it. So now all I'm gonna do is explain what I have done here. Hyperbilirubinemia. First, if there is increase in the production of bilirubin, which unconjugated bilirubin, beyond the capacity of the liver to conjugate it, obviously it is going to be very high in the blood, leading to unconjugated hyperbilirubinemia. An example, okay? So hypothetically, let's say hypothetically, in time 1 minute, 100 units of unconjugated bilirubin is produced by our spleen. In the same time, 1 minute, 100 units of unconjugated bilirubin is conjugated into 100 units of conjugated bilirubin. Okay, means all the unconjugated bilirubin produced by the spleen is conjugated by the liver in the same period of time. So is there any extra bilirubin left? No, it's not. Good. But let's say due to any pathological reason, now in the same time t equals to 1 minute, instead of 100 bilirubin being produced, 1000 bilirubin, unconjugated bilirubin, gets produced in the spleen. But in the same time t equals to 1 minute, the capacity of the liver is still the same. It still conjugates 100 unconjugated bilirubin to 100 conjugated bilirubin. That means how many extra unconjugated bilirubin remains in the blood? Subtraction, brother. 1000 minus 100, 900. There is still extra 900 unconjugated bilirubin in your circulation. Too much unconjugated bilirubin, unconjugated hyperbilirubinemia. Point 2. Let's say the production is normal. Okay, 100 UB is being produced. Now this 100 unconjugated bilirubin, it attaches with albumin in the systemic circulation. Let's say this plasma protein binding does not take place. Then what? Then what will happen? The unconjugated bilirubin is transported to the liver by albumin via plasma protein binding. If plasma protein binding will not take place, unconjugated bilirubin, which is free now, not bound to any protein, will not reach the liver. If it will not reach the liver, conjugation will not take place. Why is conjugation required? I've already taught you conjugation is required to get conjugated bilirubin. Why? To excrete it out. To excrete it out of the body. So if UB is not transported by the albumin, since there is no plasma protein binding, conjugation will not take place and subsequently excretion will also not take place. Unconjugated bilirubin will get accumulated, free unconjugated bilirubin will get accumulated in the blood, also leading to hyperbilirubinemia, which unconjugated hyperbilirubinemia. Number 3, let's say production is also normal. Plasma protein binding is also normal. So the albumin takes all the 100 UB to the liver. But the problem is here in the liver. The unconjugated bilirubin uptake does not take place. There is impairment in the uptake. As a result, same thing. Conjugation will not take place. Excretion will not take place. Unconjugated bilirubin will get accumulated in the blood, leading to unconjugated hyperbilirubinemia. Number 4, let's say production is normal, plasma protein binding is normal, uptake is normal, but now in the hepatocyte, the process of conjugation is impaired. As a result, unconjugated bilirubin is not converted to conjugated bilirubin. Then what? Same thing. Excretion will not take place. Unconjugated bilirubin will get accumulated in the liver cell, and then it will be pushed back into the circulation, leading to unconjugated hyperbilirubinemia. Till this point, these defects at number 1, 2, 3, and 4 led to increment in the level of unconjugated bilirubin in blood, leading to unconjugated hyperbilirubinemia. Distal to this, or after this, all the defects is going to lead to accumulation of conjugated bilirubin in the blood, leading to conjugated hyperbilirubinemia. Let's see how. Okay, so till here everything's fine. Conjugated bilirubin is formed. What happens to conjugated bilirubin? It leaks into the portal circulation. But then this leaked conjugated bilirubin is reuptaken with the help of OAT1B1, 1B3 transporter. Let's say this reuptake does not take place. So now all the conjugated bilirubin will get accumulated in the portal circulation, and eventually from there it will enter the systemic circulation, and now you have increased level of conjugated bilirubin, conjugated hyperbilirubinemia. Okay, let's say reuptake is fine. Okay, conjugated bilirubin is now secreted into the biliary canaliculi, but now secretion does not take place. See, secretion does not take place. Accumulation of conjugated bilirubin, and then it is pushed back into the circulation again. Let's say secretion is fine also. Now conjugated bilirubin is secreted into the biliary canaliculi. It has to travel through the biliary duct system. But then there is problem with the bile flow. What will happen? Conjugated bilirubin will get accumulated. It will get pushed back. It will be pushed back. Accumulation, pushed back into the circulation. Rise in conjugated bilirubin in circulation. Conjugated hyperbilirubinemia again. See? At each point of the metabolism, I showed you the defect leading to increase in level of bilirubin in the blood, where before this point at step 1, 2, 3 and 4, the defects led to unconjugated hyperbilirubinemia, and distal to that point at step 5, 6 and 7, it led to conjugated hyperbilirubinemia. So one last revision. There is increase in the production of unconjugated bilirubin beyond the conjugating power of liver. Increase in bilirubin. Number 2, there is decrease in the binding of unconjugated bilirubin with albumin. So there is too much free unconjugated bilirubin in the blood. Increment. Number 3, the unconjugated bilirubin that reaches the liver does not enter the cell of the liver. So conjugation does not take place. So there is increase in unconjugated bilirubin in blood. Number 4, within the liver, the process of conjugation does not take place. Increase in unconjugated bilirubin. Till here, unconjugated hyperbilirubinemia. After that, the conjugated bilirubin leaks into the portal circulation, but it is supposed to be reuptaken into the liver. Reuptake does not take place. Too much conjugated bilirubin in circulation. The conjugated bilirubin is secreted into the biliary canaliculi. Secretion does not take place. Too much conjugated bilirubin in the liver, which gets pushed back to the circulation. Let's say secretion takes place. After that, it has to pass through the bile system. But then there is some blockage. There is decrease in the bile flow. All the conjugated bilirubin gets accumulated in the biliary duct system, pushed back into the liver and back into circulation. That's it. Now what you need to know? Now what you need to know is that for individual reasons, what are the pathologies backing it off? That is, okay, there is increase in production of unconjugated bilirubin leading to unconjugated hyperbilirubinemia. But what causes the increase in production? What causes the decrease in plasma protein binding? What causes the decrease in uptake? What causes decrease in conjugation? What causes the decrease in reuptake? What causes the decrease in secretion? What causes the decrease in bile flow? Let's see. Starting off with unconjugated hyperbilirubinemia. Again, before this, all of it, 4 of them, unconjugated hyperbilirubinemia. Starting off with production. First, increase in production. What causes increased production of bilirubin? Hemolytic anemia. When there is hemolytic anemia, there is excess hemolysis. That is excess breakdown of RBC, excess degradation of hemoglobin, leading to excess production of bilirubin. Simple. Excess production of unconjugated bilirubin in the spleen. Simple. Second, hemolytic anemia. Then resorption of internal hemorrhage. Whenever there is internal hemorrhage or internal bleeding, what happens? There is accumulation of RBCs leading to formation of hematoma. All the RBCs present in the hematoma gets broken down, dies, gets eaten up by macrophage and converted into bilirubin. Which bilirubin? Unconjugated bilirubin. So, unconjugated hyperbilirubinemia. Third, impaired erythropoiesis or defect in erythropoiesis. Let's take an example of pernicious anemia. What happens in pernicious anemia? In pernicious anemia, there is increase in the rate of production of erythrocytes in bone marrow, red bone marrow, or there is accelerated erythropoiesis. During accelerated erythropoiesis, along with increase in the production of RBCs, there is also increase in the destruction of immature RBCs. So new RBCs are being made fast, but at the same time, immature RBCs are being killed faster as well. So the macrophage, they will eat up the immature RBCs, leading to increase in the production of unconjugated bilirubin. See, let's take an analogy, all right? You are given bunch of resources. You are given glue, paper, paintbrush, paint, some stickers to make a collage. You use those resources to make the collage. But then when you make the collage, you cut a piece of paper, throw out a part of it. You use glue, not all of it gets used, it gets thrown as well. Paint as well, you use some of it, you throw some of it. Stickers as well, you use some of it, you throw some of it. So the end collage that you get is your RBC, and the resources that you have thrown are the hemoglobin that got wasted away during the production of the new RBC. That is why when more RBC is being made, more hemoglobin is getting wasted, and these hemoglobin are being eaten up by the macrophage, being converted into bilirubin. Accelerated erythropoiesis, but subsequently increase in the destruction of immature RBCs as well, and increase in the production of unconjugated bilirubin as well. Okay. Second, decrease in plasma protein binding. Do you remember your pharmacology? Something called sulfonamides. See, sulfonamides, they have a higher affinity to albumin. That is why they displace the unconjugated bilirubin and itself attaches with, they displace the unconjugated bilirubin and itself attaches with albumin. So now what happens? There is free unconjugated bilirubin in the blood, free unconjugated bilirubin, leading to increase in the level, unconjugated hyperbilirubinemia. What if this condition is present in a neonate? Okay, a new terminology for you guys. Kernicterus. Ever heard of it? Side effect of, you might have read that the adverse effect of sulfonamide is kernicterus in neonate. What is that? See, let's say there is a newborn, and this newborn has an infection. So the doctor prescribes sulfonamide to the newborn. What will sulfonamide do? The sulfonamide will compete with unconjugated bilirubin. Since it has a higher affinity towards albumin, it will displace the unconjugated bilirubin and itself go and sit there. So there is increase in the level of unconjugated bilirubin in blood, free unconjugated bilirubin in blood. And I have taught you that unconjugated bilirubin, since it is lipid soluble, it is highly permeable. Okay, this is one part of the story. Second part, in a newborn child, the blood-brain barrier is not well developed. It is poorly developed. So now this lipid soluble unconjugated bilirubin can easily permeate through the blood-brain barrier and enter the central nervous system. Then this unconjugated bilirubin will go and deposit in the basal ganglia and other nuclei of the central nervous system, leading to brain damage, neurological damage. This is kernicterus. Once more. What will sulfonamide do? It will displace unconjugated bilirubin. So now there is increase in the level of free unconjugated bilirubin. This will cross the poor blood-brain barrier present in the neonate, and then it will go and accumulate, or it will go and deposit in basal ganglia of central nervous system and other nuclei. This leads to brain damage and neurological damage. That is kernicterus. Good. All of this is occurring in a neonate. Remember, because they have poorly developed blood-brain barrier. That's why the free unconjugated bilirubin can easily permeate through it. All right. Third, reduction in uptake. Another pharmacology, rifampicin drug. Heard of it? Anti-TB drug. Okay. Rifampicin, it inhibits uptake. As a result, unconjugated bilirubin is not taken up by the hepatocyte. That is why mild hyperbilirubinemia is seen in TB patients going through anti-TB therapy or DOTS. Then decrease in conjugation. Decrease in conjugation. As soon as I say decrease in conjugation, first thing is physiological jaundice. Physiological jaundice of newborn, and as well as breast milk jaundice. So this is quite an interesting topic. That is why I'll take this topic separately. Okay, so I'll explain this topic. I'm not leaving it behind, but then separately at the end of the lecture, okay, or in a different lecture. Conjugation. Okay. See, conjugation. Decrease in conjugation. Decrease in conjugation. Why would a decrease in conjugation take place? A very important reason for decrease in conjugation is decrease in activity of the enzyme responsible for conjugation. See, what is happening in the conjugation? Unconjugated bilirubin is converted to conjugated bilirubin by the conjugation of glucuronic acid to unconjugated bilirubin. And for this, the help of enzyme glucuronosyl transferase is required. The help of GT is required. So GT is responsible for conjugation in liver. Let's say this GT is either impaired, that is, it does not function properly, or it is less in amount, then conjugation will not take place. Simple. So now you need to know different conditions where the function of GT is impaired or the GT itself is less or absent. As a result, conjugation does not take place. Let's see those conditions. Okay. First, there is neonatal deficiency of GT. Second, there is mild deficiency. Okay, I'm not going to use red only for the conditions. Neonatal deficiency of GT. Mild deficiency of GT. Then partial deficiency of GT and complete deficiency of GT. Neonatal deficiency of glucuronosyl transferase leads to physiological, I'm going to write in short, physiological jaundice of newborn. This right here, okay? Physiological jaundice of newborn. That is, there is deficiency of glucuronosyl transferase in a newborn. The reason it is called physiological is because it is normally present in all newborn. In all newborn, normally there is less amount of glucuronosyl transferase in their body, or deficiency of glucuronosyl transferase in their body. The reason being, the gene that is responsible, the expression of gene that leads to the formation of this protein, glucuronosyl transferase, is still not, the gene is still not expressed in the chromosome yet. Got it? See, gene is responsible for the production of protein. The gene, there has to be a gene that is responsible for the production of glucuronosyl transferase as well. In a newborn, this gene is not yet expressed in the chromosome. That is why they have deficiency of GT. Since there is deficiency of GT, conjugation does not take place in the newborn. That is why mild hyperbilirubinemia is seen in newborn for at least 1 week. Okay. That is why for 1 week, for around 1 week, mild hyperbilirubinemia is seen, and around after 3 to 4 months, everything becomes normal because the gene is now well expressed, the same as that in adult. How much the gene is to be expressed in adult is now expressed within 3 to 4 months. Mild deficiency, this is seen in Gilbert syndrome. I missed out one thing, right? So I said here in the third step of unconjugated hyperbilirubinemia, decrease in uptake. So it's not just rifampicin that brings decrease in uptake, but also Gilbert syndrome. Gilbert syndrome also brings sometimes decrease in uptake. But then the main concern with Gilbert syndrome is the mild deficiency of glucuronosyl transferase. Partial deficiency, that's Kriegler, Najjar, Najjar syndrome type 2, and complete deficiency, that is Kriegler, Najjar syndrome type 1. Okay, mild deficiency. Since in Gilbert syndrome there is only mild deficiency, it is mostly asymptomatic. But manifestation of symptom takes, right? Manifestation of symptoms takes in special condition like stress, fever, and pregnancy. As for type 2 Kriegler-Najjar syndrome, there is partial deficiency, right? In newborn, since it is a congenital defect, in newborn there is partial deficiency of glucuronosyl transferase, for which you use phenobarbital as drug therapy. What phenobarbital does is that it increases the production of, it forcefully increases the production of GT. It forcefully triggers that gene to produce more glucuronosyl transferase. As for type 1, there is complete deficiency. There is no GT at all in the body. That means conjugation in this baby does not take place. There is no conjugation at all in the baby. There is huge increase or accumulation of unconjugated bilirubin in the blood. That is why this is 100% fatal. The baby dies. Okay, so that was all for unconjugated hyperbilirubinemia. First, increase in the production of unconjugated bilirubin itself by hemolytic anemia or resorption of hematoma or impaired erythropoiesis like seen in pernicious anemia. Number 2, decrease in plasma protein binding due to sulfonamide poisoning. 3, decrease in uptake of unconjugated bilirubin by the liver due to rifampicin or Gilbert syndrome. 4, decrease in conjugation as seen in physiological jaundice of newborn and breast milk jaundice. But most importantly, 3 congenital abnormalities: Gilbert syndrome, Kriegler-Najjar syndrome type 1 and Kriegler-Najjar syndrome type 2. In Gilbert syndrome, there is mild deficiency of GT. In Kriegler-Najjar syndrome type 1, there is partial deficiency of GT. And in Kriegler-Najjar syndrome type 2, there is complete deficiency of GT. In Gilbert syndrome, due to mild deficiency, it is asymptomatic, but symptoms are manifested during special conditions like stress, fever, and pregnancy. Kriegler-Najjar syndrome, there is partial deficiency in the baby of GT, so phenobarbital is given as drug therapy. As for permanent solution, that is liver transplant. In Kriegler-Najjar syndrome type 1, there is complete deficiency, so there is absolutely no GT, no conjugation taking place, so it is 100% fatal. Okay. Second, conjugated hyperbilirubinemia. Everything distal to this leads to conjugated hyperbilirubinemia. Starting off with decrease in reuptake. Decrease in reuptake takes place due to OAT1B1 / OAT1B3 mutation, which is seen in Rotor syndrome. Second, decrease in secretion into biliary canaliculi. Secretion takes place by which protein? Multi-drug resistant protein 2. So if mutation takes place there, obviously the secretion is not going to take place, and it is seen in Dubin Johnson syndrome. Next, decrease in bile flow. So first was decrease in reuptake. For that, if mutation takes place in OAT1B1, 1B3, there is decrease in reuptake. That is, these proteins, they are no longer functional, so reuptake does not take place, and that is seen in Rotor syndrome. Second was decrease in secretion. So decrease in secretion takes place when the protein responsible for secretion is mutated. There is mutation in multi-drug resistant protein 2, which is seen in Dubin-Johnson syndrome. Third is decrease in bile flow. Decrease in bile flow can take place, number one, when there is obstruction in the flow, right? Obstruction in the flow, or if there is inflammation. So two conditions: cholestasis and cholangitis. Since both of them are really big topics, I'm gonna have lectures differently for these two topics as well. All right. Another question: what is the main difference between Rotor syndrome and Dubin-Johnson syndrome? The difference is, in Dubin-Johnson syndrome, the liver, it is black or highly pigmented, liver. So when you do the biopsy of the liver grossly, it is black pigmented. The reason being, in Dubin-Johnson syndrome, there is accumulation of catecholamine metabolite, right? Epinephrine metabolite. After the metabolism of catecholamine, what metabolite remains, it goes and deposits in the liver in Dubin-Johnson syndrome, leading to blackening of the liver, because that metabolite itself gives that black pigmentation. Good. All right. Okay, we talked about unconjugated hyperbilirubinemia. We talked about conjugated hyperbilirubinemia. But there's a very important, shall I say, the most common pathological defect that actually causes both. That causes increase in unconjugated bilirubin as well as an increase in conjugated bilirubin. So if you use your tiny brain, you can guess that such a pathology has to occur at intersection between the both, right? The yellow and the white intersection between the both. So somewhere around here, that pathology has to occur. So let's see that pathology. Let's say the inflammation of the hepatocyte cell right here takes place. Due to inflammation, there is loss of function of the cell. As a result, conjugation does not take place. As a result, there is accumulation of unconjugated bilirubin in the blood. Good. Due to inflammation, there is increment in the size of the hepatocyte. Okay. Due to increment in the size of the hepatocyte, what happens? It presses upon the outflow. It presses upon the various outflow. The cells, they press against one another, and they also press upon the biliary canaliculi. So there is obstruction in biliary canaliculi. As a result, even after conjugation, the conjugated bilirubin, it does not have any outflow to go through. It can't go out of the cell because it is constricted within. It is trapped within the cell. So there is increase in conjugated bilirubin, accumulation of conjugated bilirubin, and it is pushed back into the circulation. Again, there is inflammation of the hepatocyte. Due to inflammation of the hepatocyte, there is loss of function of the cell. Due to loss of function of the cell, conjugation does not take place. Since conjugation does not take place, there is accumulation of unconjugated bilirubin in the cell. This accumulated unconjugated bilirubin in the cell gets pushed back into the circulation, leading to increment in the level of unconjugated bilirubin in the blood and unconjugated hyperbilirubinemia. Done. Since there is inflammation, there is increment in the size of the cell. These cells, they press against one another, and they also press the biliary canaliculi, leading to obstruction in the biliary canaliculi. As a result, the conjugated bilirubin is unable to be excreted out of the cell. So it gets accumulated in the cell, and the accumulated conjugated bilirubin gets pushed into the circulation as well. As a result, there is increase in the level of conjugated bilirubin or conjugated hyperbilirubinemia. There is both, brother, there is both. And the inflammation of hepatocyte is seen when? It is seen in hepatitis. But then the better thing to say is hepatocellular defect. in hepatocellular defect or injury like hepatitis and cirrhosis. Hepatitis and cirrhosis. In hepatitis, cirrhosis, any sort of hepatocellular defect like chronic liver disease, right? There is increment of both conjugated and unconjugated bilirubin. Okay, so every point that I have mentioned has been mentioned in this table, and this table is from Robbins. So every point I have said is indeed from Robbins. There are few topics remaining for which I have a different lecture. One is the physiological jaundice of newborn and breast milk jaundice, and then a short video on just the congenital hyperbilirubinemia. Now we know all the etiological factors responsible for hyperbilirubinemia. Let's quickly recap all the congenital hyperbilirubinemia. Starting off with congenital defect, where genetic mutation takes place such that there is impaired uptake of unconjugated bilirubin from blood circulation into hepatocyte. As a result, there is accumulation of unconjugated bilirubin in blood circulation, leading to unconjugated hyperbilirubinemia. And this condition is seen in which syndrome? It is seen in Gilbert syndrome. Okay, so that's the first congenital defect or genetic defect. Second is a genetic defect that leads to deficient production of glucuronosyl transferase. Glucuronosyl transferase is responsible for the process of conjugation. So if there is deficiency in glucuronosyl transferase, conjugation will not take place, leading to accumulation of unconjugated bilirubin and unconjugated hyperbilirubinemia as well. Now, there is three types of deficiency that can take place. Either the deficiency is mild, the genetic mutation is not that strong, or there is partial deficiency, or there is the worst of the worst, complete deficiency of glucuronosyl transferase. The question is, in which particular syndrome are such deficiencies seen? Mild deficiency is seen in Gilbert syndrome. Partial deficiency is seen in Crigler, I repeat, Crigler-Najjar syndrome. However, it is of two types, type 1 and type 2. This is seen in Crigler-Najjar syndrome type 2. Complete deficiency is seen in Crigler-Najjar syndrome 1. So 1 is much worse. Since in Gilbert syndrome, there is mild deficiency, so the condition is mostly asymptomatic. But there are special conditions where symptoms manifest, and they are, so the symptoms manifests in stress, fever, and pregnancy. When there is partial deficiency, as seen in Crigler-Najjar syndrome 2, phenobarbital can be used as drug therapy, because phenobarbital, it increases the production of glucuronosyl transferase in baby. Crigler-Najjar syndrome type 1, since there is complete deficiency of glucuronosyl transferase, absolutely no conjugation takes place, there is overload of unconjugated bilirubin in blood. So this is 100% fatal. The child, the baby does not survive. All right. So up to here, the congenital hyperbilirubinemia are unconjugated hyperbilirubinemia or congenital unconjugated hyperbilirubinemia. Next. So next is there is reduction or impaired. There is impaired reuptake. Impaired reuptake. The reason behind it is, see, reuptake of the leaked conjugated bilirubin from portal circulation back into hepatocyte takes place with the help of transporter OAT 1B1 and 1B3. Mutation in transporter OAT 1B1 and 1B3 causes impaired reuptake, and such mutation is seen in Such mutation is seen in which syndrome? Come on. Gilbert? No, it is seen in Rotor syndrome. Rotor syndrome. How can you remember? See, O for oat, and there are two O's in Rotor syndrome as well. And finally, there is impaired secretion. After the production of conjugated bilirubin in hepatocyte, it gets secreted into biliary canaliculi with the help of transporter multi-drug resistant protein 2. Mutation in multi-drug resistant protein 2 leads to impairment in secretion. As a result, accumulation of conjugated bilirubin in hepatocyte takes place and it gets pushed back into blood circulation. Such mutation is seen in Dubin-Johnson syndrome. So both Rotor syndrome and Dubin-Johnson syndrome causes conjugated hyperbilirubinemia. Both of them cause conjugated hyperbilirubinemia. The difference, what's the difference between the two? The difference is that in case of Dubin-Johnson syndrome, the liver, it becomes black. The reason is accumulation of metabolite of catecholamines in the liver in this particular syndrome. When a baby has Dubin-Johnson syndrome, the catecholamine metabolites, they get deposited in the liver, and these metabolites give black pigmentation to the liver, so the liver appears dark. Physiologic jaundice of newborn. The reason it is called physiologic is because such hyperbilirubinemia is normally seen in almost all newborn. See, when the baby is inside the womb of the mother, everything for the baby is being done by the mother herself. As soon as the baby comes out into the external environment, now the baby is independent. But the system inside the baby is still immature. So it takes time for all the system to become mature so that it can adapt to the new external environment. So in a newborn, the hepatobiliary system is also still immature. So the hepatobiliary system is unable to carry out conjugation of unconjugated bilirubin, resulting in accumulation of unconjugated bilirubin, resulting in unconjugated hyperbilirubinemia. That is why physiologic jaundice of newborn is referred to as the mild, transient, unconjugated hyperbilirubinemia of newborn. The reason it is transient is because as soon as complete maturation of the hepatobiliary system takes place, now the liver is able to carry out conjugation. So unconjugated bilirubin is converted to conjugated bilirubin, bringing back the level of bilirubin back to normal. Okay. So usually this unconjugated hyperbilirubinemia is seen for at least the first week. And usually the complete maturation of hepatobiliary system or the gain in ability to carry out conjugation takes place, adult level of maturation takes place by third to fourth month of development. Okay. The next question is, why unconjugated hyperbilirubinemia, or how unconjugated hyperbilirubinemia? There are two major answers to this. Number one, see, in a newborn, the gene in the chromosome that is responsible for the production of glucuronosyl transferase is still immature. So the gene is immature. As a result, there is deficiency of glucuronosyl transferase, and the process of conjugation also does not take place, resulting in accumulation of unconjugated bilirubin in blood, resulting in unconjugated hyperbilirubinemia. So the first case is neonatal deficiency, or the deficiency of glucuronosyl transferase in a newborn due to immature gene that is responsible for the production of glucuronosyl transferase. Simple. Okay. Second reason, see, in a newborn, the hemoglobin that is present is fetal hemoglobin. Which hemoglobin? Fetal hemoglobin. This fetal hemoglobin is to be replaced by adult hemoglobin. As a result, all the fetal hemoglobin, they get broken down, or excess hemolysis takes place, resulting in excess production of unconjugated bilirubin. Simple. So second reason is increased breakdown of hemoglobin, which fetal hemoglobin, so that it can be replaced by adult hemoglobin, resulting in excess production of unconjugated bilirubin. So on one hand, more and more hemoglobin is being broken down, which fetal hemoglobin is being broken down, resulting in excess production of unconjugated bilirubin. On the other hand, unconjugated bilirubin is not getting conjugated. Unconjugated bilirubin is being produced at excess, and it is also not being conjugated. So where will all of them go? They will accumulate in the blood, resulting in unconjugated hyperbilirubinemia. So that's physiologic jaundice of newborn. Second is breast milk jaundice. See, the breast milk contains two important chemicals that are responsible for bringing about, again, unconjugated hyperbilirubinemia. So the breast milk contains two chemicals that also bring about unconjugated hyperbilirubinemia. So both physiologic jaundice of newborn and breast milk jaundice is characterized by unconjugated hyperbilirubinemia. So what are the two chemicals? Here's the breast milk. The breast milk contains first beta glucuronidase. It has A's at the end. That means it is responsible for breaking down something, and it is responsible for breaking down the glucuronic acid bond of the conjugated bilirubin. When the baby sucks milk, the milk enters the gastrointestinal tract. Inside the gut, what is present? Conjugated or unconjugated? Conjugated bilirubin. So along with the breast milk also goes the beta glucuronidase. Along with the breast milk also goes beta glucuronidase. This beta glucuronidase brings about deconjugation. It breaks down conjugated bilirubin, brings deconjugation of conjugated bilirubin to unconjugated bilirubin, and this unconjugated bilirubin gets absorbed into portal circulation. From portal circulation, it will reach the systemic circulation, resulting in increase in level of unconjugated bilirubin. Second chemical that is present is the metabolite of progesterone, or pregnanidiol. Okay, what does it do? Pregnanidiol, it gets absorbed from the gut into the systemic circulation. From the circulation, it reaches the liver. Inside the liver, inside the hepatocyte, it goes and inhibits glucuronosyl transferase. If glucuronosyl transferase is inhibited, that means the process of conjugation is inhibited. If the process of conjugation is inhibited, that means there is accumulation of unconjugated bilirubin in blood, leading to unconjugated hyperbilirubinemia. Third, breastfeeding jaundice. See, if breast milk jaundice is as a result of breast milk, breastfeeding jaundice is as a result of absence or lack of breast milk. Completely opposite to one another. See, one last proper explanation so that you can compare between the three, okay? First, when there is a newborn, in the newborn, the hepatobiliary system is still immature. It is unable to carry out conjugation. Plus, there is excess breakdown of hemoglobin, which fetal hemoglobin, so that it can be replaced by adult hemoglobin, resulting in increased accumulation of unconjugated bilirubin in blood. So in a newborn, due to immature organ, there is physiologic jaundice of newborn. Okay. Now this newborn is fed breast milk. Let's divide the development of this newborn into two phases. Okay, the first week and then after first week. Now, within the first week, if the baby is not fed breast milk, or there is deficiency of breast milk, then this leads to breastfeeding jaundice. Okay, so breastfeeding jaundice has early onset. Breastfeeding jaundice has early onset within first week. Okay, So within first week of the development of the baby, if the baby is not fed breast milk, then the jaundice is breastfeeding jaundice. But after first week, if the baby is fed breast milk, there is a chance that that breast milk can worsen the case of physiologic jaundice of newborn, exacerbate. So breast milk jaundice, on the other hand, has late onset. It is usually after first week, and it can exacerbate, that means worsen physiologic jaundice of newborn. Got it? So within first week, if no breast milk, breastfeeding jaundice. After first week, breast milk can lead to breast milk jaundice and worsen the case of physiologic jaundice of newborn. Okay. So within first week, if there is no breast milk, okay, so there is no breast milk, or there is deficiency of breast milk. The primary source of nutrition to baby, to a newborn, is breast milk. So if it does not receive any breast milk, what will happen? No nutrition plus no water, dehydration. Dehydration leads to decrease in peristalsis. So if peristalsis does not happen, more absorption from gut will take place. Since peristalsis is not happening, food is not moving, the content of the GIT is not moving because peristalsis is not happening. So there is more time for absorption. So more bilirubin present within the GIT gets absorbed, leading to hyperbilirubinemia. And that is it. One last revision. Okay. There's a newborn. In this newborn, the hepatobiliary system is still immature. It is unable to conjugate unconjugated bilirubin. Plus, there is excess breakdown of fetal hemoglobin to be replaced by adult hemoglobin, resulting in accumulation of unconjugated bilirubin in blood, resulting in unconjugated hyperbilirubinemia. Since such condition is normally seen in almost all newborn, it is called physiologic jaundice of newborn. This condition remains for at least first week, and the complete maturation of the organ takes place so that conjugating power is completely attained. The adult level of conjugating power is attained by 3rd to 4th month of development. Okay. Now, after the newborn is, after there's your newborn, within first week of development, I repeat, within first week of development, if there is deficiency in breast milk feeding, there is dehydration in the newborn, resulting in decrease in peristalsis, resulting in more absorption from GIT, resulting in increased absorption of bilirubin and increased level of bilirubin in blood, resulting in breastfeeding jaundice. So breastfeeding jaundice has early onset within the first week. After first week, when the baby is fed breast milk, due to two important chemicals in the breast milk. Number one, beta-glucuronidase, which breaks down or deconjugates conjugated bilirubin in gut back into unconjugated bilirubin, which gets absorbed from the GIT into portal circulation. And number two, pregnanidyl, which goes into the liver and inhibits glucuronosyl transferase, inhibits conjugation. So there is accumulation of unconjugated bilirubin in blood. Due to these two chemicals, after first week, there is exacerbation or worsening of physiologic jaundice of newborn, and this is called breast milk jaundice. So breast milk jaundice has late onset after first week of development. This is the most important video within this series, because finally now you are going to learn the actual concept of jaundice, and then the three types of jaundice: prehepatic, hepatic and post-hepatic jaundice, and finally, very important, liver function tests that will allow you to distinguish between prehepatic, hepatic and post-hepatic jaundice. So first things first, what is the difference between hyperbilirubinemia, jaundice and icterus? See, within your blood, the total bilirubin level normally is 0.3 milligram per deciliter to 1.2 milligram per deciliter. So this is the normal range of total bilirubin in your serum or blood. This is the normal range, that is 0.3 milligram per deciliter to 1.2 milligram per deciliter. When the serum total bilirubin level becomes greater than the normal upper limit, that is greater than 1.2 milligram per deciliter, then that condition is referred to as hyperbilirubinemia. Hyper, excess, bilirubinemia in blood, the presence of excess bilirubin in blood, the presence of bilirubin beyond the normal upper limit, that is even if it is 1.3 milligram per deciliter, it is still greater than the upper normal limit. This is hyperbilirubinemia. But just because a patient has hyperbilirubinemia doesn't mean he also has jaundice. So what is jaundice? See, the level of bilirubin is greater than the upper limit, 1.3 milligram per deciliter, greater than 1.2 milligram per deciliter. So the patient has hyperbilirubinemia. Now, let's say the pathological defect causing hyperbilirubinemia in that patient is not being taken care of. As a result, the bilirubin level keeps on rising, 1.3 milligram per deciliter, then 1.4 milligram per deciliter, then 1.5 milligram per deciliter, then 1.6 milligram per deciliter, then 1.7 milligram per deciliter, then 1.8 milligram per deciliter, then 1.9 milligram per deciliter, and around 2 to 2.5 milligram per deciliter. At around this point of hyperbilirubinemia, physical, clinical manifestations are appreciable by naked eye. At this point, when such clinical features are well appreciated by naked eye, what kind of manifestation? So when bilirubin is at around 2 to 2.5 milligram per deciliter within the blood, this high level of bilirubin, significant level of bilirubin, they go and deposit at certain parts of your body like skin, sclera, the white part of your eye, mucosa, and the interstitial fluid. Leading in, bilirubin itself is yellow in color. So if they go and deposit in skin, sclera, mucosa, and interstitial fluid, it is going to turn those parts yellow as well, leading in yellow discoloration. And this yellow discoloration is finally referred to as jaundice. So just because there is increased level of bilirubin, it doesn't mean the person has jaundice. It simply means there is hyperbilirubinemia. But when hyperbilirubinemia is significant, that is around at least 2 to 2.5 milligram per deciliter, then there is so much hyperbilirubinemia that bilirubin go and deposit in skin, in sclera, in mucosa, in interstitial fluid, turning them into its own color, that is yellow. Now this is called jaundice. So finally, the definition. First, hyperbilirubinemia. When the level of total serum bilirubin is greater than the upper normal limit, greater than 1.2 milligram per deciliter, we refer to it as hyperbilirubinemia. But the yellow discoloration of skin, mucosa, sclera, and interstitial fluid due to significant hyperbilirubinemia of at least around 2 to 2.5 milligram per deciliter is referred to as jaundice. So a very important statement here. Not all hyperbilirubinemia leads to jaundice. See, when bilirubin, total serum bilirubin level is 1.3 milligram per deciliter, at this point the person has hyperbilirubinemia, but the person does not have jaundice. So not all hyperbilirubinemia leads to jaundice, but all jaundice is due to significant hyperbilirubinemia. So the person has jaundice at this point, right? That is, there is yellow discoloration of skin, mucosa, sclera, and interstitial fluid. This is due to significant hyperbilirubinemia of at least around 2 to 2.5 milligram per deciliter. So there is increase in bilirubin, yellow discoloration is not seen. Increase in bilirubin, yellow discoloration is not seen. There is hyperbilirubinemia, but yellow discoloration is not seen. There is hyperbilirubinemia, but yellow discoloration is not seen. And then at a significant level of hyperbilirubinemia of around 2 to 2.5 milligram per deciliter, finally yellow discoloration is appreciated, and this is called jaundice. That means not all hyperbilirubinemia leads to jaundice, but when there is jaundice, it is due to significant hyperbilirubinemia, at least of 2 to 2.5 milligram per deciliter of total bilirubin in blood serum. I can't make the concept clearer than this. Okay, now see, I said there is deposition of bilirubin in jaundice in skin, in sclera, in mucosa, and then interstitial fluid. But I have written the sclera in yellow. Why? Because the yellow discoloration of just the sclera, I repeat, the yellow discoloration of just the sclera due to significant hyperbilirubinemia is referred to as icterus. So see, the total yellow discoloration of skin, sclera, mucosa, interstitial fluid due to significant hyperbilirubinemia is your full-blown jaundice. Okay, that's your jaundice. But when you are referring to just the sclera, the yellow discoloration of the sclera, also due to the same significant hyperbilirubinemia, that is icterus. Okay. Now, first question, why yellow discoloration? If you know your heme metabolism, you must know that heme is red in color. When heme gets broken down into biliverdin is green in color. Then biliverdin gets reduced to bilirubin, and bilirubin is yellow in color. So if bilirubin goes and deposits somewhere, it is going to impart yellow coloration to that somewhere. Simple. So it goes and deposits where? In the skin. It goes and deposits to sclera and interstitial fluid. It goes and deposits in mucosa, turning them yellow in color. Okay. So, okay, it goes and deposits in skin, sclera, mucosa, interstitial fluid. Why did people decide to give the yellow discoloration of just the sclera a special name of icterus? Why is it so special? This is the reason why it is special. See, when jaundice is about to happen, right? So the level of bilirubin is greater than the upper normal limit of 1.2 milligram per deciliter. That is hyperbilirubinemia. Then bilirubin level rises, leads to significant total bilirubin, significant hyperbilirubinemia of around 2 to 2.5 milligram per deciliter. At this point, bilirubin goes and deposits at various parts of the body, leading to its yellow discoloration. Right. Now, the reason the yellow discoloration of sclera has been given special name is because this yellow discoloration of sclera is manifested very fast. Okay, that is the very first physical sign that is seen. That is even before bilirubin deposits in skin or mucosa or interstitial fluid, it first goes and deposits in the sclera. So there can be a person with yellow discoloration of sclera but no yellow discoloration of skin yet occurred. It will occur later on, but first it's the sclera that has gone yellow. The skin is yet to become yellow, mucosa is yet to become yellow. That is, if bilirubin level keeps on rising further, the bilirubin will go and deposit in skin. See, first bilirubin goes and deposits in sclera. So first yellow discoloration of sclera is seen, and this yellow discoloration of sclera due to significant hyperbilirubinemia is icterus. So icterus is the first physical sign of jaundice. Later on, when bilirubin level rises even more, it goes and deposits in other parts like mucosa, skin, and interstitial fluid. So since yellow discoloration of sclera is seen first, it is given a special name of icterus. So if a patient with hyperbilirubinemia comes to you, right? Comes to you. And this patient has physical sign of icterus, right? Physical sign of yellow discoloration of sclera. That means this patient is soon going to develop full-blown jaundice. That is yellow discoloration of skin, mucosa interstitium is going to appear soon after icterus. That's why it's clinically important. Another question. Why is it that yellow discoloration of sclera is seen before skin, mucosa and interstitial fluid? Or let's say before skin and mucosa. Why before skin and mucosa? Three major reasons. Number one, sclera is white in color. So when bilirubin goes and deposits there, imparting yellow color, it is quite contrasting over the white background. White background, yellow discoloration, visible quite easily appreciable by naked eye. Number two, sclera has high vascularity, so more bilirubin can go there. Number three, high elastin. See, bilirubin, why is it going and depositing in skin, mucosa, sclera? Why? Because these structures, they contain high amount of elastic fibrous connective tissue, and bilirubin loves elastic fibrous connective tissue. And out of all these three, your sclera has highest amount of elastic fibrous connective tissue. So bilirubin loves elastic fibrous connective tissue. In sclera, it is going to find lots of elastic fibrous connective tissue, and it is going to go and deposit there. Okay, that's it. Now finally, the types of jaundice. Let's see. Aita, jaundice, which is the yellow discoloration of skin, sclera, mucosa and interstitial fluid as a result of significant hyperbilirubinemia of at least around 2 to 2.5 milligram per deciliter. It is of three types, depending on the pathological defect occurring either before liver, within liver or after liver. If you know your heme metabolism, this is going to be really easy. And yes, I've already explained heme metabolism in detail. But even if you don't know it, no worries. I'll explain it here itself. Very short, very short. Only the significant point you require to know the types of jaundice. See, so there is your liver. There is activities taking place before liver and activity taking place after liver. Before liver, during heme metabolism, what happens? The red blood cell, it gets broken down. The hemoglobin gets broken down. The heme gets broken down, and the heme is converted to unconjugated bilirubin, which is lipid soluble but bound to albumin. The process which allows this to occur is referred to as hemolysis. The breakdown of hemoglobin to unconjugated bilirubin is hemolysis. After hemolysis, the unconjugated bilirubin present within your blood is carried to your liver by albumin. So unconjugated bilirubin is first uptaken by the liver cell. Then the process of conjugation takes place, which converts unconjugated bilirubin to conjugated bilirubin. Conjugated bilirubin is water soluble and excretable. The process that allows this conversion is conjugation. So conjugation takes place. After that, conjugated bilirubin from the hepatocyte is secreted into biliary canaliculi. Biliary canaliculi. The biliary canaliculi, as you must know from your general anatomy, not the general anatomy, but the anatomy of gastrointestinal tract, it opens into second part of the duodenum. So the conjugated bilirubin is secreted into biliary canaliculi. From there, through the biliary duct, the bile duct, it enters the second part of the duodenum. This is your bile flow. So conjugated bilirubin enters the duodenum along with the bile. The bile contains bile salt and acid, and the thing that makes bile salt and acid, that is cholesterol, and this conjugated bilirubin. Okay, so if pathological defect occurs before liver in the process of hemolysis, it leads to prehepatic jaundice. If pathology or defect occurs within the liver, then that is hepatic jaundice. If pathology occurs after the liver in bile flow, then that is leading to jaundice, then that is post-hepatic jaundice. Simple. So first you have prehepatic jaundice. prehepatic jaundice, where the pathology is before the liver in the process of hemolysis. See, so first, RBC containing hemoglobin, hemoglobin with heme, heme is broken down by the process of hemolysis into unconjugated bilirubin. If there is excessive hemolysis, too much hemolysis, either in adult or in infant, there is excess hemolysis, this will result in production of excess unconjugated bilirubin, and that will lead to unconjugated hyperbilirubinemia. So this jaundice, prehepatic jaundice, is associated with unconjugated hyperbilirubinemia, and the reason behind it is excessive hemolysis. Since the cause is excessive hemolysis, it is also referred to as hemolytic jaundice. Simple as that. Again, since the cause resulting in the jaundice is before the liver, it is prehepatic jaundice. Since the cause is excess hemolysis resulting in breakdown of huge amount of hemoglobin to huge amount of unconjugated bilirubin, the jaundice is also referred to as hemolytic jaundice. Since there is excess breakdown of hemoglobin into unconjugated bilirubin, the jaundice is associated with unconjugated hyperbilirubinemia. Second is due to defect within the liver. So it is referred to as hepatic jaundice. Hepatic jaundice. What happens is the cell of the liver or the hepatocyte somehow gets injured, referred to as hepatocellular injury. Now this injury is most commonly due to hepatitis, like viral hepatitis, or it could also be due to liver cirrhosis. Be it hepatitis or liver cirrhosis, at the end of the day, there is hepatocellular injury. And when there is hepatocellular injury, two things happen. Number one, the cell of the liver loses its function. As a result, conjugation does not happen, resulting in elevated level of unconjugated bilirubin, resulting in unconjugated hyperbilirubinemia. But there is second thing that happens. That is, the cell, the hepatocyte, it inflames or grows larger in size. Hepatitis, there is inflammation. The cell grows larger in size. It swells up, right? Due to swelling up of the cell, the biliary canaliculi gets compressed. The adjacent biliary canaliculi to the cell gets compressed. So whatever conjugated bilirubin is there has nowhere to escape, because the escape door is closed. The biliary canaliculi, the adjacent hepatocytes, they grow larger in size and they press on one another, closing the biliary canaliculi, press on one another, closing the biliary canaliculi. As a result, the conjugated bilirubin has nowhere to escape. So where does it go? It goes back into the blood circulation, resulting in conjugated hyperbilirubinemia as well. So in hepatic jaundice, both unconjugated and conjugated hyperbilirubinemia is seen, and the cause behind it is hepatocellular injury due to hepatitis or cirrhosis. So it is also referred to as hepatocellular jaundice. That's why it's also referred to as hepatocellular jaundice. All right. The third type of jaundice, that is after, due to pathology after the liver. So referred to as post-hepatic jaundice. Post-hepatic jaundice. After a liver, what is there? See, within the liver, conjugation takes place. Unconjugated bilirubin is converted to conjugated bilirubin. Now this conjugated bilirubin is spelled out into the duodenum along with bile. So it passes through the biliary system. Bro, there's your liver, there's the there's your left hepatic duct, the right hepatic duct that combine to form the common hepatic duct that meet with the cystic duct, resulting in the formation of common bile duct that meets the pancreatic duct, forming the hepatopancreatic duct that leads to ampulla of water that opens into second part of duodenum via sphincter of Oddi. You know that, right? So bile comes through all these ducts and enters the second part of duodenum. Along with the bile comes conjugated bilirubin as well. But within this bile flow, if obstruction occurs anywhere within the liver or outside the liver, obstruction occurs, what will happen? Conjugated bilirubin will be accumulated within the hepatocyte. It won't get into the duodenum. Now the escape door is closed due to obstruction. So all this conjugated bilirubin will be expelled back into the circulation, resulting in conjugated hyperbilirubinemia. The reason behind it is obstruction of the bile flow. Obstruction of the bile flow, also referred to as cholestasis. Cholestasis. That's why we call it obstructive jaundice as well. That's it. So there's 3 types of jaundice. If it is due to pathological defect occurring before the liver, it's prehepatic jaundice. If it is due to pathological defect occurring within the liver, it is hepatic jaundice. And if it is due to pathological defect occurring after the liver, then that's post-hepatic jaundice. Before liver, the pathological defect that occurs is excessive hemolysis. So the jaundice due to excessive hemolysis is also referred to as hemolytic jaundice. Within the liver, the pathological defect that occurs is hepatocellular damage, either due to hepatitis like viral hepatitis or liver cirrhosis. So jaundice due to hepatocellular damage is referred to as hepatocellular jaundice. After the liver, the pathological defect that leads to jaundice is obstruction in the bile flow, which is also referred to as cholestasis. So the jaundice is also referred to as obstructive jaundice. In hemolytic jaundice, since there is massive destruction of hemoglobin, converting it into unconjugated bilirubin, it is associated with unconjugated hyperbilirubinemia. Since in hepatic jaundice or hepatocellular jaundice, there is hepatitis inflammation of the cell leading to loss in function of the cell, resulting in increase in unconjugated bilirubin, but at the same time swelling of the cell that compress over one another and completely obliterate the bile canaliculi, sorting of the escape door for conjugated bilirubin, resulting in increment in conjugated bilirubin. So it is associated with both unconjugated hyperbilirubinemia and conjugated hyperbilirubinemia. In post-hepatic jaundice, since there is bile flow obstruction, conjugated bilirubin can't enter the duodenum. Along with conjugated bilirubin, the content of the bile, that is bile salt and acid and cholesterol, they don't enter the duodenum, so they get pushed back into the circulation, resulting in conjugated hyperbilirubinemia as well as increase in level of bile salt and acid and cholesterol in the blood. That's it for the types of jaundice. Now, very important topic that you need to know, and that is the liver function tests that will help you distinguish in between prehepatic, hepatic, and post-hepatic jaundice. Let's see. Beginning off with prehepatic jaundice, which is also referred to as hemolytic jaundice. It is referred to as hemolytic jaundice because the defect occurs within hemolysis. There is excessive hemolysis. Due to excessive hemolysis, there is excess breakdown of hemoglobin, resulting in increase in unconjugated bilirubin. See, when there is excess hemoglobin, there is excess hemolysis, there is excess breakdown of hemoglobin and excess production of unconjugated bilirubin. Okay. So, first bilirubin level. Total bilirubin, total serum bilirubin. There is a rise in total serum bilirubin. Serum unconjugated bilirubin. There is a rise in serum unconjugated bilirubin. Serum conjugated bilirubin. Serum conjugated bilirubin remains normal. Why? Because there is no problem with the cell, hepatocyte. So conjugation taking place is normal. So normal amount of conjugated bilirubin is being produced. Second, there is no problem with the bile flow. So whatever conjugated bilirubin is being made, it has a way to enter the duodenum. So there is normal level of conjugated bilirubin in blood serum. As for unconjugated bilirubin, it is elevated due to excess hemolysis. Okay. Now see, there is excess breakdown of hemoglobin. There is excess hemolysis resulting in excess production of unconjugated bilirubin. So there is excess unconjugated bilirubin in blood. This excess unconjugated bilirubin reaches the liver. So there is excess uptake. This excess unconjugated bilirubin goes through the process of conjugation. So there is maximum conjugation by the liver taking place. Maximum conjugation. Maximum potential of the liver to conjugate is taking place because there is excess unconjugated bilirubin. So liver is trying its best to conjugate as much unconjugated bilirubin as possible. As a result, there is also increment in conjugated bilirubin, but there is increment in conjugated bilirubin inside the hepatocyte, not in blood. That is why in blood, the serum conjugated bilirubin remains normal. It's in the hepatocyte where conjugated bilirubin is high. And fortunately, the bile flow is normal. So all this conjugated bilirubin, it will enter inside the duodenum. Now there is excess conjugated bilirubin, high conjugated bilirubin in the duodenum. Again, not in blood. And this conjugated bilirubin, all of it is gonna get broken down by gut bacteria into urobilinogen. So there is excess urobilinogen in gut. Urobilinogen has two ways to get excreted out. One is through urine, another is through feces. So in urine, urobilinogen is gonna be high. In stool, urobilinogen is gonna be high as well. So you get the concept, right? Excess hemolysis, excess unconjugated bilirubin in the circulation, which gets taken up by the liver. So in the liver cell also excess unconjugated bilirubin. Conjugation in full potential is taking place. Liver is trying its best to conjugate all unconjugated bilirubin. So there is maximum amount of conjugated bilirubin being produced. Since bile flow is normal, so there is maximum amount of conjugated bilirubin in the duodenum. There is maximum amount of urobilinogen within the duodenum, and this urobilinogen has two ways to come out, either through urine or through stool. So there is maximum amount of urobilinogen in urine and maximum amount of stercobilinogen in stool. So that's there. Urine urobilinogen is high, stool stercobilinogen is high as well. Okay, now the presence of bilirubin in urine, is it there or not? See, I've already taught you that bilirubin is of two types, conjugated bilirubin and unconjugated bilirubin. Conjugated bilirubin, which is formed from unconjugated bilirubin within the liver, it is water soluble. Again. There is unconjugated bilirubin, which is produced from the breakdown of hemoglobin, and conjugated bilirubin, which is produced from unconjugated bilirubin by the process of conjugation in the liver. Unconjugated bilirubin, it is lipid soluble, but it is bound to albumin. Conjugated bilirubin, on the other hand, it is water soluble and excretable. Again, unconjugated bilirubin is bound with albumin, so it is large in size, so it can't pass through the filtration membrane of the kidney within the nephron. In between glomerulus and nephron, there is filtration membrane. This large albumin bound unconjugated bilirubin cannot pass through that filtration membrane. So it will not enter the nephron. It will not be there in your urine. It is the conjugated bilirubin, if it is present in blood, since it is first not bound to albumin and number two water soluble, it can pass through the filtration membrane and be present in the urine. Got it? So it is conjugated bilirubin. If it is present in blood, it is visible in urine as well, because it is the excretable form. So it is present in urine as well. Now, in prehepatic jaundice or hemolytic jaundice, there is rise in which bilirubin? Unconjugated bilirubin. There is rise in unconjugated bilirubin. and I said that unconjugated bilirubin is bound with albumin, so it can't spill into urine. So there is no bilirubin in urine. Again, if urine has bilirubin, it is conjugated bilirubin, because it is only conjugated bilirubin which is water soluble and an excretable form that can be in urine. Unconjugated bilirubin can't be in urine. So in hemolytic jaundice, there is rise in the level of unconjugated bilirubin in blood, and this unconjugated bilirubin will not enter the nephron, so it can't be in the urine. So urine does not have any bilirubin. Now another concept, when there is bilirubin in urine, the urine becomes cola colored, and this cola colored bilirubin present urine, more specifically cola colored conjugated bilirubin present urine, is referred to as choluria. But in hemolytic jaundice, there is no bilirubin in urine, so there is no cola colored urine, so there is acholuria. Okay. Second, hepatic jaundice or hepatocellular jaundice. The reason behind hepatic jaundice or hepatocellular jaundice is hepatocellular injury. So there is your hepatocyte. This hepatocyte goes through hepatocellular injury. This hepatocellular injury can be due to inflammation, right? Hepatitis, or simply cirrhosis. After hepatocellular injury, I've already said two things happen. Number one, there is loss in function of the cell. As a result, conjugation does not take place. Unconjugated bilirubin accumulate, it gets pushed back into the circulation. Number two, there is swelling up of the cell, and the adjacent cell swells up and blocks the biliary canaliculi. It obliterates the biliary canaliculi. As a result, conjugated bilirubin can't escape out of the cell. Accumulation of conjugated bilirubin, it will be pushed back into the circulation as well. So there is total serum bilirubin. There is a rise. Serum unconjugated bilirubin, also there is a rise. Serum conjugated bilirubin, also there is rise. As for urobilinogen, the urine urobilinogen remains normal, but the stool urobilinogen, it decreases. Not the urobilinogen, sorry. In stool you have stercobilinogen. Stercobilinogen imparts brown coloration to the stool. Since there is low stercobilinogen in stool, the stool is going to be pale in color. Now, there is rise in which bilirubin? Both unconjugated and conjugated bilirubin. Unconjugated bilirubin can't get filtered into the nephron. Fine, because it is too large, being bound with albumin. But conjugated bilirubin can be. So this conjugated bilirubin does get filtered through the filtration membrane, and conjugated bilirubin gets filtered through the filtration membrane and enters the nephron and is visible within the urine, giving urine cola color, referred to as choluria. So there is choluria. Due to choluria, the urine is brown in color, and due to less stercobilinogen in stool is pale in color. So the patient presents with pale stool and dark urine. Now, these are not the important, they are important, but not the most important tests for hepatocellular injury or hepatocellular jaundice. The most important thing is this. See, within hepatocyte, there are enzymes. And due to hepatocellular injury, the cell is going to be broken. Obviously, the cell is going to be broken. And then there is going to be leakage of whatever enzyme is present inside the cell outside. The enzyme is going to leak outside. After leaking outside, where will the enzyme go? It will enter the blood circulation. So when you perform blood test you'll find an elevated level of these liver cell specific enzymes. These enzymes present within the hepatocyte enzymes. What are these enzymes? They are AST, aspartate transaminase, and ALT, alanine transaminase. So once there is injury to the cell, they simply leak out of the cell. They leak out of the cell. As a result, there is rise in the level of AST and ALT in blood. AST, ALT level rises. And there is significant rise because all the AST and ALT enzyme present within the cell is going to leak out into the blood circulation. So there is going to be significant rise in AST and ALT. See, I said after hepatocellular injury, two things happen. Number one, loss in function, and number two, swelling of the cell. Due to swelling of the cell, these two are hepatocytes. They swell up due to hepatocellular injury. As a result, in between one hepatocyte and the other hepatocyte, there is bile canaliculi. Due to the swelling of the cell, the bile canaliculi gets compressed. There is compression of the there is compression. See, here is one cell, here is another cell. Let's say there is compression of the bile canaliculi. Then whatever is present within the bile canaliculi will be spilled back into the cell and then back into the circulation. Simple logic. If there is obstruction here, whatever is present within the bile canaliculi can't move forward. It will be spilled back into the cell and back into the circulation. Now within the bile canaliculi, on the wall of the bile canaliculi as well as within the bile canaliculi, there are important enzymes. These enzymes, they are either present on the wall of the bile canaliculi or they are there secreted by the hepatocyte itself. And these are gamma glutamyl transferase and 5-NT. Again, they are ALP, gamma GT and 5-NT. So there is increased level of ALT, gamma GT and 5-NT as well. But remember, first what is happening? First there is injury to the cell, and due to injury to the cell, the AST and ALT within the cell leaks out of the cell, resulting in early and significant rise in AST and ALT. Okay, let me write it. So there's going to be early and significant rise in AST and ALT. But after a while, swelling of the cell also results in compression of the bile canaliculi, resulting in late or delayed and minor rise in the biliary canalicular enzyme like ALT, gamma GT and 5-NT. So there is early and significant rise in hepatocytic enzyme, but late and minor rise in the biliary canalicular enzyme in case of hepatic or hepatocellular jaundice. Okay. The final type of jaundice, that is the post-hepatic or obstructive, wait, it's supposed to be in pink, obstructive jaundice. Okay, this is due to obstruction in bile flow. When there is obstruction in bile flow, conjugated bilirubin, it doesn't have the way to enter the duodenum. So there is accumulation of conjugated bilirubin within the cell, and it gets spilled back into the circulation, resulting in increased level of conjugated bilirubin in blood circulation. So what happens? Due to obstruction in bile flow, there is obstruction in bile flow. obstruction in bile flow, also referred to as cholestasis. Cholestasis. It results in total serum bilirubin increases, serum conjugated bilirubin increases, but then the serum unconjugated bilirubin is normal. That's because the process of hemolysis is normal. It's just that there is obstruction in the biliary outflow. So the conjugated bilirubin can't escape into the duodenum. So it is pushed back into circulation. Accumulation of conjugated bilirubin in circulation, increase in conjugated bilirubin in circulation, resulting in conjugated hyperbilirubinemia. Okay, so that's there. Now see, very important point. The fastest way to detect the presence of obstructive jaundice or post-hepatic jaundice or cholestasis in a patient is simply to perform dipstick in the urine of the patient. Dipstick in the urine of the patient. And when you examine the urine of the patient, you will find that there is no urobilinogen in the urine. Why? See, there is obstruction in the bile flow. So the conjugated bilirubin from the hepatocyte will not enter the duodenum. So there is no conjugated bilirubin in duodenum. So there is no urobilinogen in duodenum. So there is no urobilinogen in urine, and there is no stercobilinogen in stool. So there is no urine urobilinogen, and there is no stool stercobilinogen. There is rise in which bilirubin? Rise in conjugated bilirubin. Can conjugated bilirubin get filtered? Yes, it is water soluble. It is an excretable pulp. It can get filtered into the nephron. So it is present in the urine, and the presence of bilirubin or conjugated bilirubin, to be more specific, in urine is referred to as choluria, which gives urine its cola color. In this case, the presence of pale stool due to absence of stercobilinogen and dark urine due to presence of bilirubin in urine is even more appreciable. So there is pale stool with dark urine, highly appreciable in post-hepatic jaundice. In hepatic jaundice, there is low level of stercobilinogen, so the stool is not completely pale. But in post-hepatic, there is absolutely no stercobilinogen, so the stool is very pale and the urine is dark due to conjugated bilirubin. Okay. See, since there is obstruction in the bile flow, what is going to happen? The biliary enzymes that are either stuck on the wall of the bile canalicula or present within the biliary duct system will get acted upon by the bile salts, right? Because there is accumulation of bile salt, there is accumulation of bile here, the bile is unable to go forward. So this bile accumulated here is going to act on these enzymes present on the wall or within the lumen. They are going to act, and then they are gonna break it off the wall, and it's gonna enter the cell and then into the blood circulation, resulting in increase in their level. What are they? They are the ALP, alkaline phosphatase, gamma GT, and 5-NT. So there is increase in their level, increase in their level due to bilirubin. Eventually, since bile salts are getting pushed into the cell, the bile salt is obviously toxic to the cell. It is going to harm the cell, and the cell is going to get damaged as well. So the enzymes present within the cell is going to come out later on. Eventually, what is present within the hepatocyte? AST and ALT. So they will leak out. After damage to the cell. So there is going to be rise in AST and ALT, but then the rise is not significant and occurs later. So first early and significant rise, early and significant rise is that of biliary canalicular enzyme. But late, delayed, and minor rise is that of hepatocytic enzyme in case of post-hepatic or obstructive jaundice. When there is obstruction, it's not just the conjugated bilirubin that is being obstructed, right? It is the bile salt that is being obstructed. It is the cholesterol that is being obstructed. So conjugated bilirubin is pushed back to circulation, resulting in conjugated hyperbilirubinemia. But at the same time, bile salt and cholesterol is also being pushed back to circulation. So there is bile salt in blood circulation, cholesterol in blood circulation. Bile salt, when they reach the skin, they cause frequent itching, and this is referred to as pruritus. So due to bile salt, there is pruritus. And as for cholesterol, they will go and deposit underneath the skin, resulting in xanthoma. So the patient presents with pruritus and xanthoma due to the presence of bile salt and cholesterol in blood circulation. Yep, that's it. Obviously, we are going to revise all of that at the end, okay? So I want you to answer them, even though I can't hear you, but then match the answer with this, what I'm going to write right now. So there's pre-hepatic, hepatic, and post-hepatic jaundice. Again, the same thing. First, total bilirubin, then unconjugated bilirubin, then conjugated bilirubin, then Vandenberg reaction. Then we are going to shift to urine and stool. Urobilinogen in urine or urine urobilin, stercobilinogen in stool or stool stercobilin, and then presence of bilirubin in urine, which is urine bilirubin. Then the presence of bile salt in urine or urine bile salt. Then within the hepatocyte, you have AST-ALT that leaks out into blood circulation. So you are going to see AST-ALT, the hepatocytic enzymes. Then within the bile canaliculi, you have ALP, gamma GT, and 5-NT, the presence of those in the blood. And then the other lab diagnosis that you can do, or other diagnosis that is appreciated as well. Okay, first, serum total bilirubin. All three is a case of jaundice, and jaundice has hyperbilirubinemia. So serum total bilirubin is a reason in all three jaundice. In pre-hepatic jaundice, there is excess hemolysis resulting in excess or elevated unconjugated bilirubin, resulting in unconjugated hyperbilirubinemia. So unconjugated bilirubin is a reason in pre-hepatic jaundice. In hepatic jaundice, due to hepatitis or hepatocellular injuries, there is loss of function of the cell, so conjugation does not take place. Unconjugated bilirubin is a reason. In post-hepatic jaundice, it's normal. Pre-hepatic jaundice, conjugated bilirubin is normal. In hepatic jaundice, due to inflammation or swelling of the cell, they compress on one another, obliterating the bile canaliculi space. As a result, whatever conjugated bilirubin is present within the hepatocyte won't come into the bile canaliculi because there is no bile canaliculi. It has been compressed. The conjugated bilirubin is pushed back into circulation. So there is elevated level of conjugated bilirubin in hepatic jaundice as well. In post-hepatic jaundice, due to obstruction to bile flow or cholestasis, there is conjugated hyperbilirubinemia. Vandenberg reaction. Short, what is Vandenberg reaction? Vandenberg reaction is a biochemical test that is used to detect bilirubin. Not just bilirubin, detect bilirubin, but to distinguish the type of bilirubin in blood serum. See, if within blood serum there is conjugated bilirubin, then when you put a Vandenberg reagent in it, it shows coloration. Since the reaction is direct, there is direct reaction. Since conjugated bilirubin shows direct reaction with Vandenberg reagent, it is also referred to as direct bilirubin. If there is unconjugated bilirubin in serum, after you put Vandenberg reagent, color is not seen. But then after you put another reagent like alcohol, color is seen. Now since there is indirect reaction, the unconjugated bilirubin is also referred to as indirect bilirubin. When there is both conjugated bilirubin and unconjugated bilirubin, upon addition of Vandenberg reagent, due to the presence of conjugated bilirubin, coloration is seen. But upon addition of alcohol again, due to the presence of unconjugated bilirubin, the color becomes even darker. Since the reaction is taking place in two phases, we refer to this as biphasic reaction. Okay. So in prehepatic jaundice, there is unconjugated bilirubin which gives indirect reaction. In hepatic jaundice, there is both conjugated and unconjugated bilirubin, so it gives both reactions, so biphasic reaction. In post-hepatic jaundice, there is just conjugated bilirubin which gives reaction directly, so there is direct reaction. Okay, now urine urobilin. In prehepatic jaundice, urine urobilin is increased, stool stercobilin is increased. In hepatic jaundice, urine urobilin is normal, stool stercobilin is low. In post-hepatic jaundice, due to obstruction to bile flow, nothing enters the duodenum. So there is no conjugated bilirubin in the duodenum, there is no urobilinogen in duodenum, so there is no urine urobilin, there is no stool stercobilin. Okay, now urine bilirubin. In prehepatic jaundice, unconjugated bilirubin has risen, and unconjugated bilirubin is bound to albumin. It is not excreted into the nephron. So there is no urine bilirubin detected, which is referred to as acholuria. In hepatic jaundice, there is conjugated bilirubin. It can enter the urine. So there is choluria. In post-hepatic, there is conjugated hyperbilirubinemia. Conjugated can enter the urine. So choluria. Urine bile salts. In prehepatic jaundice, there is urine bile salt. In prehepatic jaundice, there is absent of urine bile salt. Wait, let me just give a cross. There is no urine bile salt. Because, see, in prehepatic jaundice, the bile flow is normal. So the bile, it can enter the duodenum. So if bile does not come, the bile salt does not enter the blood circulation, it does not go to the kidney. So there is no bile salt in the kidney. So there is no bile salt in the urine. Similarly in hepatic as well, slight amount of urine bile salt. Why? Because in hepatic jaundice, along with loss of function of the cell, there is also swelling of the cell, resulting in compression of the bile canaliculi. So there is certain level of obstruction taking place. When there is obstruction taking place, the bile salt will not enter the duodenum. It will be pushed back into the circulation. From the circulation, it can reach the kidney. From the kidney into the nephron. So slight level of bile salt is seen. But in post-hepatic jaundice, there is full-blown obstruction, complete obstruction. So all of the bile salt gets pushed back into the circulation, enters the kidney, and then is found in the urine. So there is elevated urine bile salt. AST, ALT. Okay. Prehepatic, there is no AST, ALT level is normal. ALP gamma GT level 5 is also normal. We need to distinguish between hepatic and post-hepatic jaundice. In hepatic jaundice, since first there is hepatocellular damage, there is leakage of AST ALT. So there is fast and significant rise in AST ALT. But later on, due to swelling of the two cell, compression of the bile canaliculi, blockage of the bile canaliculi, presence the bile canaliculi enzymes, it gets pushed back into the cell and into the circulation. So delayed and minor rise takes place. As for post-hepatic jaundice, due to obstruction to the bile flow, due to cholestasis, there is significant and early rise in ALP, gamma GT, 5-NT, or basically bile canalicular enzymes. But later on, the bile salt that gets regurgitated back, will damage the cell as well, and the AST-ALT leaks out. So there is delayed but slight rise in AST-ALT. As for other, in prehepatic jaundice, there is excess hemolysis taking place, and hemolysis can either be intravascular hemolysis or extravascular hemolysis, and the biochemical features of both intravascular and extravascular hemolysis I have taught in detail under hemolytic anemia under my one-shot video of anemia. Hepatic jaundice, since there is loss of function of the cell, the prothrombin time increases as well. If it is acute, just the prothrombin time increases. But if it is chronic injury to the cell, then albumin level in the blood decreases as well, because the liver cell stops making albumin. As for post-hepatic, there is cholestasis. Due to cholestasis, the conjugated bilirubin is pushed back into the circulation. But at the same time, bile salt and cholesterol is also pushed back into circulation. Due to bile salt, there is pruritus, and due to cholesterol, there is xanthoma. That's it.